So today we're joined by Julia Bueno, author and psychotherapist with more than 20 years of experience, and she's written two brilliant books. One is called Everyone's a Critic, How We Can Learn to Be Kind to Ourselves, which I highly recommend. And the second is called The Brink of Being, Talking About Miscarriage. And that's what we're going to be exploring with Julia in our conversation today, pregnancy loss, and how we can best support our clients when they are dealing with grief that follows pregnancy loss or the struggles of infertility. So thank you so much for joining us today, Julia. We're really excited to have you with us.
Thank you very much for such kind words and for having me.
So how would you like to begin? Would you like to kind of give us a little potted version of your story, perhaps?
Yeah, sure. And maybe also as to why I wrote the book in the first place. So I'm a psychotherapist by trade, and I began my professional life as a lawyer. But after my first pregnancy ended in a very late miscarriage of baby girls, twin girls, who I named Matilda and Florence. And that was quite an event in my life, as you can imagine. And I mean, I'd been thinking about changing tack professionally, wasn't quite sure, but that experience and the support I had after it sort of galvanised my thinking about retraining in some sort of counselling or therapy and wanting to support people who'd been through experiences similar to mine. This was over 2 decades ago. Things are a bit different than they are now. So while training as a psychotherapist, I also can offer my support to a charity that is still in existence. It's called the Miscarriage Association, and back then there were about 3 websites on the internet, and it was still sort of dial up. And I remember calling the charity and speaking to the national director there, who's just been made an OBE on the New Year's Honours list, which I'm so delighted by, Ruth Bender-Attic. Had a lovely chat with her on the phone and decided to do some support work for the charity after that, and then later became a trustee of the charity. Meanwhile, I retrained and qualified as a psychotherapist and was quite keen to kind of carry on my interest and my experience in supporting women and couples who had suffered reproductive loss. After my first miscarriage, I did have a live birth and had 3 more miscarriages and then another one. So my reproductive story didn't kind of end there. So after a kind of few years went by, I was sort of culminating lots of clinical experience and support experience and advocacy experience. I was doing a lot of advocacy work for the charity in my role as a trustee and otherwise. I thought I wanted to put it all down and in paper. And it was, no surprise to you guys, I'm sure, that it was a good 15 years actually before I felt I could write about it. I needed that. I didn't know I needed it, but I needed that length of time and that distance to be able to write about it. And I mean, the book itself is not just a memoir. I hope I keep myself sort of not out of it, but the main stories are other people's stories, and each chapter explores a different experience of miscarriage, which is a very broad experience. Legally, it can happen from the day you find out you're pregnant until the 24th week of pregnancy, and when it legally becomes a stillbirth. So it's a very broad experience, but I also wanted to explore the experience of not conceiving at all, which in my clinical experience can be felt very much like a lost baby, because what I dig into the book is this idea of a child in mind. And each chapter, as I say, explores a different experience of miscarriage through the sort of vehicle of a composite case study. So that it's a fictionalised case study. Obviously, I couldn't write about people directly and had to be aware of confidentiality. So there are lots of stories that are rolled into one and a bit of my own. And I also got really super excited about the kind of history of pregnancy and pregnancy loss, and wrote far too much about that, which my editor stripped out. But there's a bit of history in the social science and kind of psychological research which was then pretty contemporary. But the book came out in 2019, didn't it? Gosh, so things have moved on, and actually the research has moved on in lots of positive ways. So it is a bit out of date in terms of just the facts, but I think it's fair to say that the stories and the experiences are still pretty relevant today as they were when I wrote it.
Yeah,
Very
because we were
much so.
talking before you came on really about this. We call it the Grief Olympics. You know, it's like you get different medals depending on which kind of loss it is, and you know, oh, my loss is much worse than your loss, and that disenfranchises grief for people, doesn't it? And that came through really, really strongly in the book for me. That the baby in mind, you know, it's as significant a loss, but it's like, well, you know, this is worse, and that seems certainly to have been your experience.
Yeah, and thank you for flagging that up, because you know, like, I haven't heard that experience, that expression before. But you know, this sort of pecking order of grief or grief policing absolutely goes on in this realm. Yes, a sort of stillbirth is noted more than, you know, a miscarriage of just a 5-week pregnancy. But as you say, it's very much my experience, and I'm glad that came across in the book, is that, you know, I've spoken to couples, for example, who someone might miscarry after a few days of knowing she's pregnant, but she spent 10 years trying to get pregnant, and that baby in mind, that maybe even a child in mind, you know, adult child in mind, that they've kitted out the nursery and thought about the school and what they're going to name their child, and month after month of not conceiving is a real loss. So yeah, it can be absolutely devastating.
When I read your book, I could not put it down. I read it with the view of very contemporary. I'm a grief practitioner, educator, so I read it through that lens, and I read it through the lens of the grieving brain and how we form connections and those bonds, those attachment bonds. You made me see even more so, because I can get too complacent, the fact that of course it's a grief reaction. Of course it's a grief reaction. And it's not just a grief reaction because of how many days or months or what the nature was, but they were planning for that, as you've just said. They were planning for that child in mind. Could be years in the planning. And that's when we start to form those bonds, those connections.
Yeah, I was desperate to find, and I did talk to some sort of attachment experts and researchers, sort of desperate to find a kind of imprint in the brain, as it were. And I think I did refer to some research with a Spanish researcher. But just it was my sort of desperation to convey to the reader that this is something really real and really profound. Yeah. Which the outside world doesn't understand much at all. But also this sort of, I mean, it's not, I don't want to reduce it as simple, but, you know, when a woman has a bump, then people get it. People think, baby, you know, proto-human or sort of human. I mean, this whole, it's such a confused bond, because it's a bond, as I say, with whom, with what. And we get very confused in our society about that.
Is that because,
about what we
because the relationship is so immediate and private and personal up to a stage, because, you know, they've not been shared, and this, not secrecy about 3 months, but this, it's a thing, isn't it, still, to not talk as much?
It is. I've never understood it, because no doctor I've ever met, even 20 years ago, nurse or midwife, has ever said keep it quiet. It's just a sort of something that women have carried through the generations. Which is a whole other piece about women in kind of medical paradigm that we have. Yes, I mean, it doesn't help that by keeping it quiet, there's a sort of sense of sort of suppressing this notion of something that is very important and profound and idiosyncratic. I think that's the other thing, is that, you know, we're obviously talking very generally, but I also try and be clear in everything I say and write that, I mean, it's my experience as somebody who's supported people through the grief, that, you know, not to presuppose or assume that I know what that bond means, because of course it is idiosyncratic, and I do meet women and men who kind of interestingly come to me and kind of go, whoa, the midwives are really kind of gave me a memory box and suggest I have counselling, and, you know, this for what? This wasn't a baby, this was just a pregnancy. I mean, as you know, with your work generally, that, you know, a grief is, we share so much, but it is idiosyncratic, and it's so important to kind of tune in and listen to what that bond meant.
Yeah. And you said that your experience galvanised you to start training. So I'm wondering if you can maybe speak a little bit about what your experience of therapy was like before you trained.
Yeah. I mean, I was very, very lucky in that I had a fantastic therapist who got it. She was great. I think, well, I can't speak for her, but it was interesting because I had a couple of, I can't remember, lost them, I definitely had one, I think 2 miscarriages during my 5-year training. A lot of people didn't get it, including my tutors and my peers. And that's something I have done along the way also, is train counsellors and therapists, because it's not something that is on the curriculum. And I'm sure I know, Trudy, we've had that conversation before, but there are lots of topics that are still really wanting on, I think, a lot of training curriculi. Is that the plural? I can't speak for them all, but I certainly know of a couple of, because I supervise trainees who are in training, and I've got a vague idea of what they do and they don't learn. And it's pregnancy loss, reproductive loss is just not on it. Bolted on a fairly cursory amount of training and grief generally. It's sort of seen as a sort of specialist thing that you might go on to do, but it seems extraordinary given that there isn't a human on the planet who hasn't experienced grief of some sort.
Yeah.
And we know that, the rule of thumb is 1 in 4 pregnancies end in miscarriage. You're pretty guaranteed as a counsellor or therapist to come across it, if not directly with your client, then their friend or their sister or their brother or their child, or the list is so long, isn't it?
So what are your thoughts here about counsellors supporting clients struggling with baby loss, maybe struggling with infertility, who don't have lived experience themselves?
Well, it's a tricky one, isn't it? Because, I'll answer your question and I'll come back to it. I think I don't think that should sort of hold any counsellors back. I think, we hope that counsellors in training can empathise and sympathise and have the imagination of what it might be, what it may be like for your client, just in the same way that, I will never know what erectile dysfunction feels like as a woman, or being, a black woman in the world. I won't have that experience either, but I read and I talk and I learn and I speak to peers, and that's the best that we can do, I think, is alongside being very curious. It's about asking questions as well, isn't it? It's being with your clients. Tell me what happened. Tell me what it's like. I've been doing this work for many, many years now, and I regularly say, look, I haven't got a clue what this feels like. Tell me what it's like. I like to think I sort of keep up that humility, even if I think I know. So I would encourage any counsellor, just to ask questions. And my experience is, especially with especially with disenfranchised griefs, but there are some griefs that have stories that are easier to tell than others and have more space for stories. But especially in the realms of disenfranchised grief, it's the bereaved really need to tell their story from the beginning to the end. And that's such an important part of the processing, isn't it? So just simply saying to someone, look, tell me what happened. Those are 4 really powerful words, I reckon. And they certainly work for me. I can still remember the people who asked that, rather than the sort of looking at the feet. So that's my short answer, is just be curious and be honest about what you don't understand. I don't think I've never had a client who gets really pissed off if I say, look, I don't understand what that means or what that word means, tell me. It's you're showing willing to enter into someone else's world. Having said all that, I'm going to slightly contradict myself, because I do understand why it might well be that a client in searching for a therapist might want to go with somebody who is a specialism or clearly knows what, because there's a shortcut. Because you might also feel like, I don't want to have to explain that. And I'm just thinking that with some of my clients, I know what all the acronyms mean, and all the, especially kind of the language of IVF. So some people might like that.
Yeah.
So I don't think there's anything wrong with wanting to have somebody who has a specialty.
Yeah.
I have to say, Trudy, reading the book gave me a world of knowledge that I didn't have, and a world of words as well, and all the words that went into with the book and the concepts. And I don't have that, and I wouldn't have that, because I don't have lived experience at all. And I found that as a therapist really helpful and useful, just to have that knowledge and that depth of understanding that I just did not have, and it's not been covered in any of my training at all. And Julie, I have to say that yesterday, relationships on the peripheral are incredibly important to me. And my lady in my local shop that I know over the years, who serves me my coffee beans, we had the most amazing conversation about her child that died stillborn, William, back in 1998. And this was only yesterday, and it was a 45-minute conversation in a shop. Your book, literally, the conversation started out, Happy New Year, I'd rather be alive this year than not. And it's like, and then she went into everything. And I could relate so much to what she was saying, because I'd literally just spent a week with your book. It was huge.
Wonderful.
it was huge for her as well. It was amazing.
Well, it's just, you just remind me that, using her son's name, William, that's another super important thing that people don't tend to think about or would ask about. And maybe, even if a baby doesn't have a body yet, or a body that they buried, or maybe they just never saw the body, they might well have named that baby. And to be able to, that's another learning point for a counsellor, if you like, just to be curious about if the baby was born, and if it's a late miscarriage, there's parents are encouraged to hold the babies, but to ask questions. Did the baby look like you, and what do you call it, and have you got any photos, or just to ask all those questions that bring the baby's life to life. Are so valuable. I think the one most valuable, just speaking personally, I had one friend who asked me if she could see the photos of my baby girls. And as you can imagine, that meant the absolute world to me. Someone was interested to see what they looked like. And, I'm not saying everyone should, because that might be very uncomfortable for some people. But my point being is just that was a gesture towards acknowledging that they existed. They were real.
It's all part of continuing bonds, isn't it?
Exactly.
It's all part of building those continuing bonds that is part of healthy grieving. It's so important. I don't know if I mentioned this to you, but the name of our company is Elephants in Rooms because it's based on the Terry Kettering poem. Have you heard the Terry Kettering poem? It's about saying the names. It's about saying the names of people who've died, because people avoid that, don't they? They're like, oh, don't say the name, because then they might break down in front of me. But if you can't name them and you can't talk about their life, it's like a double death, isn't it?
Yeah. And I always encourage people to err on the side of kind of non-caution, to because if the bereaved person doesn't want to talk about it, or doesn't want to say the name outside, you'll get the cue, and you can back away. But it's worth if you're, because I think a lot of people are benign, aren't they? They people are good. They don't want to hurt somebody who's bereaved, but it's just sort of lack of education and not knowing. So they stay away and don't mention it because they don't want to upset people. But as I say, I sort of encourage people to take that risk, because the worst thing that can happen is someone will just not want to talk about it. But it's worth it.
That could have happened with your photos as well, because you describe in your book you've had not a tricky relationship, I don't know what word to use, but with your photos I know you didn't look at them for a long time yourself. So I think if your friend would have asked to see those photos at an earlier stage, would that have been challenging for you as well? Because
Yeah, probably, but but the gesture was so huge, that level of interest.
Just the asking.
And just the asking, and also I think this whole going back to kind of baby loss in particular, that there's this sort of less so now, but definitely this received entrenched cultural idea that at 24 weeks it's a baby. Because it has a legal status and you have to go and register it. But prior to that, it's a sort of miscarriage. It makes it fuzzy, and it's not incarnate. It's not really a life. It's not really a being. It's not really so, they're photos of what type things, It becomes very liminal. And so I think the naming of a baby is perhaps much more important, because as I say, it's for so many people it is. It was a life, it was a child, it was a human entity, which is denied culturally and legally. I mean, it's in America or Australia, my babies would have been stillbirths, and everyone would have, been much more supportive, and there would have been more kind of cultural noise around it. I mean, things have really changed a lot through lots of advocacy work, through the Miscarriage Association, but also through SANS, and there are literally over 150 kind of baby loss charities now. Lots of campaign work, and the National Bereavement Care Pathway that's been rolling out for the past 5 years, and training of midwives. So there are many more kind of specialist midwives, and I think I was telling Trudy, I know that there was in South Wales, and I can't remember which hospital it was, but somebody I know spent a long time raising money for a specialist bereavement suite in the maternity hospital. It took over a long period of time so that women who knew that they were going to have a stillbirth or a late miscarriage could do so separated from the labour ward, so that they wouldn't have to give birth around healthy live births. And unfortunately, because of funding, they were desperate for another room, and that room lasted about 9 months. So this tends to be something I hear quite a lot, is that, when A&E is overrun and a woman presents as miscarrying, well, she's not a medical emergency. Go home with some paracetamol and, come back if things, get worse or
Let
whatever.
nature take its course, which is...
All of that.
Yeah.
All of that. And there is no counselling support, or very little, for mental health full stop, let alone for bereavement support. So, yes, so much of this depends on funding and resources. There is definitely room for improvement, but I would like to acknowledge how things have come on a bit. I think we've got to the stage culturally where people tend to sort of say, if someone says, I've had a miscarriage, well, they're not whispering it anymore. They might be saying it. And people tend to say, oh, I'm sorry, much more. What would be wonderful if they get to the stage of then saying, tell me what happened, and have more curiosity about it, rather than a sort of, oh, that's a bad thing, and then kind of move on a bit.
Yeah. And you speak a lot in the book about how one of the things that can be so difficult is that sometimes there aren't the answers. That you want the answers, why is this happening, or what has happened, and there aren't the answers. And when I was reading that, I was thinking a lot about the work I do with traumatic bereavement, and so much of that work is people needing to make meaning out of what happened by trying to piece it together and trying to answer the questions that I know they're never going to be able to get answers to. For example, someone dies by suicide. You can never actually answer the whys. Yeah. So what I was wondering was, when it comes to that meaning-making process, which is so important in grieving, how as a therapist do you support that if somebody is not getting the answers that they need from the medical profession?
It's a good question, because obviously you can't provide the answer that isn't there either, so you have to support somebody with the not knowing. And particularly what comes up a lot is the pregnant woman will blame herself. I will say her partner can do too, but more often than not, part of that work is around that self-blame and making it perfectly clear that it isn't her fault. And I'm always so grateful when a doctor does say that to a woman during process or after process or along the way, because that can be so helpful to hear from the medic. But it's just so natural in the meaning making, it must be. And this is partly I think it is partly a woman back to the kind of woman in the medical paradigm thing, because women are have historically been blamed a lot for reproductive loss or reproductive, I'm using these air quotes, failures. And I write about that in the book. A lot of the kind of language is kind of misogynist and blamey. So I talk a lot with women, around and about, and unpacking their sense of, I shouldn't have eaten that, I shouldn't have drunk that, I worked too hard, I was overstressed. One thing we do know is that it's highly unlikely that either parent did, and it is just one of those things. Quite often, it's kind of we think statistically likely that it's a chromosomal abnormality, which is all part of human reproduction. There is no blame there, and although we'll never know 100% for sure, but that's something that we do have to live with, that not knowing. But yes, the unpacking the blame thing is often part of the work.
Yeah. And I think that, we speak of this quite a lot on the podcast, don't we, Martin, that as supporters, whether we're volunteers or therapists, counsellors, we have to dig into such wells of patience in ourselves, because, we're sitting across from somebody in so much pain and we want to make it better. Of course we do, because we're compassionate. We wouldn't be doing this if we weren't. But when somebody is going round and round in a loop of why, what did I do if I hadn't done this, that counterfactual thinking, and they're impatient too because they want to feel better, it can start to feed into our own impatience, can't it? And that, so we've got to really dig in and realise that it is part of the process and we're just walking alongside them. That's all we can do.
And quite often, more often than not, when I talk to a woman after a loss, she's trying to get pregnant again. And it's not that in the outside world, I say, at least you can give it another go, or it's not about replacing. The yearning never goes. So she might well be kind of grieving and recovering from that loss while also desperately hoping and trying. And so we're in this sort of parallel process of, she wants to get pregnant the next month, and when that doesn't happen, there's a loss. It feels like another loss, and it can be great impatience because, as I say, that yearning is still very, very strong. So yeah, the work can get quite complicated. You're holding quite a lot.
And you had that case study in the book where, as you were supporting somebody through multiple losses, and they lost. You got the text message of the latest one, and that was hard to read. Yeah. I'm
always in awe of. I've sat with so many women and couples who've had multiple losses, and the strength of the human spirit is quite extraordinary. To years and years of repeated losses, and the well is very deep.
So when it comes to, our listeners are generally going to be either trainee counsellors or perhaps newly qualified counsellors who want to understand grief a little bit better, and they potentially get a client who's suffered baby loss or is struggling with infertility. What are some kind of best practice things that you feel they need to keep in mind?
I suppose it sort of goes back to what I said before about, best practice always is CPD, isn't it? And learning, and, of course, I still do that. As a client presents to me with something that I don't know about, I'll busy myself doing some research to find out the best I can and use supervision. But alongside that, so that might mean, reading online, of course, but I would encourage them to read, not necessarily my book, but even just going onto some fantastic charity websites that have loads of information there. Speaking for Sounds and the Miscarriage Association, not only is there sort of the technical stuff, which I think is really important to know, about miscarriage management and what a miscarriage means, and as we've touched on today, that there's a sort of legal aspect there too, and what to expect from treatment. But also, speaking for those websites, they have lots of stories up there from bereaved women and couples. I think the most important message there is around this, which we've covered, is to dig into the child in mind and what that child in mind meant to your client, and to have that kind of curiosity and patience. And we should always be patient with our clients, but and that imagination. It can be very difficult for somebody who might never have been pregnant or has no interest in being pregnant at all. So it can be a very abstract idea.
And it is a topic around which there's just so much fear, isn't there? And I was sharing this with Martin. I was aware of it in me because it's not something I have any lived experience of. And it's something that is so devastating and so painful. I'm used to dealing with really, really traumatic loss and supporting people through stuff that other therapists might be like, well, I can't go there, it's too dark. But I still felt a little bit of fear coming up in me, on this particular angle of grief and loss. Mm-hmm. So it's having the courage as supporters, isn't it, to kind of have that fear, but lean in, not lean out.
Yes, and how do we conquer fear? It's often with knowledge and just asking those questions. But, also having said that, if it's an area that you just don't think you'll ever conquer that fear, or you don't want to work with, then that's okay too, isn't it? As practitioners, I just don't work with addiction. We'll always pass it on for my own reasons. I know that someone else can do a much better job. So, I would say that too as well. Just to be aware of your own competences and boundaries there. And one thing we haven't spoken about today, of course, it's not the disenfranchisement within the disenfranchised grief, is the partner's experience. Men are kind of socialised to be protective and supportive and stoic, and so they're quite often sort of seen, he's doing all right, he's supporting his wife. But quite often he might well have to step up and put her in the taxi and take her to hospital when she's bleeding and in agony, or nurse her for a bit and get the flowers and answer the phone and everything. But that means that his feelings can often get kind of squished. And I've heard so many time and time again stories from nurses and bereavement midwives who find the husband or the partner in the corridor sobbing because he can't bear to show it in front of her.
You covered that so well in your book as well, from your own personal story with your husband and also your case studies from that kind of disenfranchisement from the partner, the male partner being treated like as a spare or an appendage, or just not being acknowledged at all with that when they were being talked to in the room, or and then the way you described as well the really tough stuff that partner has to do as well to make the calls and I found all that incredibly fascinating from the partner perspective.
It's a little bit like anticipatory grief, though, isn't it? That somebody is maybe supporting a terminally ill partner or a terminally ill parent, and they are grieving. Understandably, all of the support and all of the care and all of the compassion is for the person who's dying. But the person, the person who's caring for them needs just as much, and they're having to compartmentalise all of that because they're having to care. So it's a little bit like that, isn't it?
And I've talked to so many men, actually relatively few men, because the men who will come to talk to me are usually dragged reluctantly by their partner, and spend the first sort of session saying, I'm fine, it's, I'm just for her, and then might open up. But for a lot of men I've spoken to, yes, exactly all you've said, but the one person that maybe the only person in the world they would talk to and open up about anything is their partner, and they just don't want to burden her, so it can compound it.
And the other thing that you mentioned, which I hadn't thought of either, was marginalised grievers.
Yeah.
And I hadn't really thought about that, but I can see how perhaps you might have a client who reveals that they miscarried as a teenager.
Yeah.
And we might automatically think, oh, well, that must have been a huge relief for you then, because that would have impacted. That's a huge assumption to make. They could have been carrying the trauma of that and the grief of that for a long, long time.
Absolutely. There was a wonderful story. I mean, she was very brave. A 15-year-old girl who volunteered her story to the Miscarriage Association. And I remember thinking at the same time, and I knew, she wasn't at my school, but I had a friend who had a baby at 15 who's now, can't do the maths, but she's well into adulthood now. And, she was absolutely fantastic. I loved her child. So to think, she'd miscarried that, so having that kind of point of reference, which so many other people sort of don't think about, as you say, too young to understand really what a pregnancy is about,
Yeah. And not underestimating the trauma as well, not underestimating the potential for PTSD.
Yes, and the research has come out to prove that, if you like, and that was a really welcome bit of research, actually. I think that it was at Imperial. I wrote about the kind of, it was a sort of the pilot study in my book, and then it came out afterwards, the kind of end published study about the risks of PTSD for the miscarriage or ectopic pregnancy. And because it hit the press, the press really ran with that. I think that really nudged things along. That's my sense anyway, people began to, in terms of the kind of mental health outcome of miscarriage, that ears were eventually pricked up.
And you speak towards the end of the book a little bit about that feeling of being a therapist, not knowing exactly how much the emotional support may feed in to physical wellness. Sort of having that sense that in holding them therapeutically, you are also supporting them, perhaps physically. So when you are aware of that, how do you manage that in yourself? How do you manage that sort of sense of, well, I mean, we've all got a sense of responsibility for clients, but especially with lived experience of knowing how that feels. How do you manage that as a therapist?
How do I manage the kind of weight of the work? I know I refer to the very thin but good research on TLC, tender loving care, which Professor Reagan. But that it's very, very old research, and we need much more of it. And that suggests that a continuity of care will affect the outcome, and it will contribute to kind of a healthy life at birth. But we need a lot more research on this. It makes intuitive sense, doesn't it? That of course that if our client is supported well and has a kind of regular support outlet, that that's going to feed into everything. Of course I get that. But as against that, I have sat with so many women who are in a complete pickle of extreme anxiety and nerves and actually can be mentally very unwell and get pregnant the 9th time and carry to term, and we don't know why. So I guess in a roundabout way what I'm saying is that I sort of disengage from the me affecting the outcome, as it were. I just sort of do the best that I can in the moment without sort of attaching any sense of responsibility for the outcome, because there's still so much we just do not understand and don't know. So yes, generally in just doing my best to help women help themselves the best they can, but without getting too... the whole stress thing is often around filtering. It's the self-blame thing as well, I think. I deliberately keep my pregnancy loss work to be a minority of my work. I mean, I can't be exact about it, but it just sort of pans out to be about a fifth of my work, and I keep it that way. I mean, I've got quite an eclectic practice because I find it particularly draining, and I think that's the best I can, for me to be the best I can at it, I need to keep it that way. I'm in awe of people. I know counsellors and therapists and bereavement workers who work with reproductive loss 9 to 5 every day, and I'm in awe of them because I couldn't do it. Because
of your personal experience, or just because of the nature and the weight of the subject?
The latter, I think. Is to say I might be, unconscious. I don't think my losses intrude. I don't sort of feel like I'm carrying that weight often. I mean, of course, it comes back occasionally, but I just find it very intense work. Yeah, because going back to this, there's so much not knowing and the uncertainty, and that's a hard thing to hold. I mean, I'm obviously really simplifying this, but if someone comes with me with mild anxiety, I'm quite confident about, I've spent 20 years working with anxiety, and I know my tools and I know my tricks, and I'm very hopeful that I can really help someone by the end of however many sessions we have. They've got some tools, and the feedback is quite instant. But when I'm working with somebody in reproductive loss, there's just no way of knowing. As I said, that kind of complicated nature of grieving a loss while trying to conceive again, and a kind of repeated loss of not conceiving, and then the terror of the first trimester, and then even after the first trimester when the 12-week scan says all is good, it's still and then you've got the 20-week scan, and sometimes women who've had repeated miscarriages will go to hospital in labour with not even a baby grow or a nappy with them because they're too terrified of believing until that baby's in their arms. So it's quite a lot of, as I say, not knowing. The direction of travel is not so certain.
So has that evolved then? Has your practice evolved that way over the couple of decades? Did you initially think that you would specialise and that would be the majority? Well,
I did think I would specialise, but I knew that I didn't want to. That didn't mean that would be all I would do. Actual, my kind of advocacy work and the other sort of work I do around it sort of is just as important, really, because as I say, I would be amazed for any human being to go through life without it touching them along the way.
Yeah, I was struck actually reading the statistics in the book, and I thought, I'm 49, and I thought to myself, over the years, how many women do I know who've had a miscarriage or a baby loss of some kind? And I could only come up with a tiny, tiny number, which says to me it was happening, but they weren't talking about it. They just didn't tell me.
I reckon. I mean, of course, we'll never know, but I really wouldn't be surprised. And as I say, things are changing and people are talking about it with greater ease now. But certainly when I had a loss, my first loss, well, all my losses, but, it would be me, because I never held back and I wasn't shy about talking about it. And it was only when I spoke about it that it gave permission for others. So many women came out of the woodwork or would say to me, actually, a few years ago I did. But there wasn't that space for that narrative. But yeah, there are more and more, and the online world has really helped that.
Yeah, and that was the other takeaway I got from the book: the online and the timeliness of the online forums and that support forums. Sometimes all the people have. is that, and how powerful that was as well to your case studies.
Yeah, and I think the same applies to so many other disenfranchised experiences in the world. That, online communities can be so powerful and important, and enfranchising and soothing and supportive. Of course, there's a lot we can get cross about, but there is. I come across so many. I was going to say life-saving, and maybe it is life-saving support online.
What next, Julia, for you, in terms of...
work. As Trudy knows actually, because we went for a walk while I was getting very bored and tired at the end of I've just sent a draft book off to my new editor about therapy speak. I'm unpacking therapy speak. So a lot of these buzzwords that people throw around, I'm just saying, hang on a minute, let's just press pause, take stock. This is what it meant when it first came out in the 1950s. This is what it means now. Here's some examples. I'm not being preachy. I'm just saying it might be useful for you to know that maybe your neighbour isn't a narcissist, and maybe your mum isn't a psychopath, and all these buzzwords. Oh, and also, there are a couple of chapters that I'm anxious about, but the use of the word trauma, and you guys probably have your own views about that because it's something that you work with, but I think we might have to come up with some other words to nuance that one. So that's a big chapter. There's one chapter look at trauma and triggers and trigger warnings, which is difficult because it sort of strays into the area of free speech, sort of the trigger warnings on campus debate, and of course neurodiversity. So yes, watch this space.